So my objectives today are to review the epidemiology and etiology of retroperitoneal fibrosis, to discuss the evaluation of patients with retroperitoneal fibrosis, to provide an overview of the medical and surgical options in the management of retroperitoneal fibrosis, and finally, to avoid mentioning the 70-centimeter snowfall at Whistler over the weekend. The sources I use for this talk are Campbell's Urology, a recent review article in The Lancet, published in 2007, the AUA Update series from 2005, published by the group at Johns Hopkins, and Medline Search. Definition of retroperitoneal fibrosis is an inflammatory fibrotic process in the retroperitoneum, encasing the aorta, IVC, and their branches, and the ureters, and other retroperitoneal structures, and at times intraperitoneal structures, including the GI tract. It's been likened to dumping cement in the retroperitoneum. The history of retroperitoneal fibrosis. This process was first described in 1905 by Alvaran, who's a French urologist. He reported on the surgical treatment of RPF in a patient with ureteral obstruction. But the disease was not officially acknowledged until 1948, when Ormond, an English urologist, published 2 cases in English. He named the disease after himself, although that never really caught on. Other synonyms for the disease include periureteritis fibrosa, periureteritis plastica, chronic periureteritis, sclerosing retroperitoneal granuloma, and fibrous retroperitonitis. Epidemiology of RPF. So the incidence is estimated at 1 in 200 to 500,000 per year, although this is difficult to estimate because of the rarity of the condition and limited literature. The male to female ratio is 2 to 3 to 1, and there is no clear genetic or ethnic predisposition. The mean age at presentation is 50, typically presents between 40 and 50, and the condition is uncommon in children and the elderly, but it has been described, like in this paper, on idiopathic retroperitoneal fibrosis in children, published by Dr. McLaughlin in 1979. This is a picture of me in 1979. So the location of retroperitoneal fibrosis. The process typically is centered at the L4, L5 level. The superior border is typically at the renal pedicle, although it can extend up into the mediastinum. And inferiorly, it typically is bounded by the pelvic brim, although it can extend all the way down into the pelvis. Laterally, it typically extends out to the outer edge of the psoas, encasing the ureters. But 15% of patients have extension outside of the retroperitoneum. So causes. 70% of cases are idiopathic, although there are some theories as to what causes the idiopathic variety that I'll go into. The other 30% are accounted for by malignancy, and 8 to 10% medications and chemicals, retroperitoneal injury, and infections. So the leading theory on idiopathic retroperitoneal fibrosis is that it's an immune-mediated chronic periaortitis related to leakage of seroid and oxidized LDL from atherosclerotic plaques. This theory is supported by the increased incidence of RPF in children with in patients with atherosclerosis and abdominal aortic aneurysms. The presence of constitutional symptoms, its association with other autoimmune diseases like lupus and rheumatoid arthritis, the increase in acute phase reactants and autoantibodies, its response to steroids and immunosuppression, and the characteristic infiltrate of plasma cells and lipid-laden macrophages seen in immune processes. This is just a diagram showing the theory on autoimmune RPF, showing a atherosclerotic plaque in the abdominal aorta with lipid-laden macrophages and leakage of these macrophages and steroid polymers into the adventitia, leading to an inflammatory response characterized by B and T cells and production of antibodies against steroid. Medications have also been implicated in RPF. The most common are ergotamine alkaloids, and their cause is thought to be mediated through serotonin. These include methylsergide and LSD. alpha blockers, beta blockers, dopamine agonists, phenacetin, haloperidol, and amphetamines. Just says it's updating the computer here. All right. So chemical causes for RPF include asbestosis, talcum powder, avatine, and methyl methacrylate. Malignant causes. So you can have primary retroperitoneal malignancies implicated in RPF. These include lymphoma, which is the most common, sarcoma, and multiple myeloma. Alternatively, you can have metastatic retroperitoneal disease from the prostate, colorectal cancer, breast, pancreatic, and gastric cancer, which incites a desmoplastic reaction and RPF. And finally, carcinoid is an interesting tumor which produces RPF without actually metastasizing to the retroperitoneum. And this is thought to be, again, serotonin-mediated and also related to the production of pro-fibrogenic growth factors like PDGF, IGF, EGF, and TGF. Retroperitoneal injury. So this can be caused by a variety of things, including radiation, trauma, surgery, either intra or retroperitoneal, and urinary extravasation. Infectious causes include repeated cholangeal or biliary tract infections, TB, chronic urinary tract infection, actinomyces, gonorrhea, schistosomiasis, syphilis, and ruptured liver echinococcal cysts. Up to 15% of patients have an associated condition, and I'll get into what these are in a second. These typically are underdiagnosed and may present either synchronously or metachromously. This is a list of some of the associated conditions, most of which are autoimmune diseases, including autoimmune thyroid disease, such as Hashimoto's or Rydell's, or Graves' disease, small and medium vessel vasculitis, ankylosing spondylitis, lupus, rheumatoid arthritis, glomerulonephritis, sclerosing cholangitis, biliary cirrhosis, sclerosing pancreatitis, and uveitis. A rare associated condition is autoimmune multifocal fibrosclerosis, which involves RPF as well as sclerosing mediastinitis, cholangitis, orbital pseudotumor, and Rydell's thyroiditis. Presentation of RPF is typically nonspecific symptoms which present 4 to 6 months prior. The physical examination is typically unremarkable, and the lab findings are nonspecific. Lower back and flank pain are the most common presentation, with 90% of patients reporting the symptom. Interestingly, the lower back and flank pain is typically non-colicky and unchanged with posture, with radiation to the lower abdomen and groin, and it's relieved by NSAIDs. Also, anorexia, nausea, weight loss, malaise, other constitutional symptoms, fever, hypertension related to renal vein involvement in up to 50% of patients, gross hematuria, testicular pain and swelling, claudication, lower extremity pain and edema, polyuria, oliguria, or anuria, and constipation. Physical exam, although it's typically unremarkable, may reveal abdominal or lumbar tenderness, a palpable abdominal mass, periumbilical bruit or abdominal aneurysm, hydrocele or varicocele, DVT, or lower extremity edema. Laboratory investigations typically include leukocytosis, eosinophilia, which is not that common, normochromic normocytic anemia, an elevation of acute phase reactants, including ESR and CRP, which is seen in 80 to 90% of patients. Positive autoimmune markers, including anti-nuclear antibody in 60%, and rheumatoid factor, smooth muscle antibody, extractable nuclear antigen, hypergammaglobulinemia, renal insufficiency and electrolyte abnormalities, and a urinalysis that commonly shows microscopic hematuria and proteinuria. This is a list of some of the structures involved in RPF. The common ones are on the left, so the abdominal aorta, IVC, ureters, and iliac vessels. See on the right, the more uncommon ones even involve the pericardium, myocardium, and even the coronary arteries. Imaging modalities used in RPF include ultrasound, CT, MRI, IVP, retrograde or antegrade pyelography, renography, and PET scanning. However, none of these modalities can reliably distinguish malignant from idiopathic RPF. Ultrasound is often the first-line imaging modality and typically shows hydroureteronephrosis present in over 97% of patients. Occasionally, a fibrotic plaque is seen, and this is typically poorly defined echopore and located over the sacral promontory, which brings us to another publication by Dr. McLaughlin. Some guy named Pat Walsh, I'm not sure. CT. So CT is often considered the gold standard in retroperitoneal fibrosis. It's important to note that contrast is contraindicated in renal impairment. However, there are some typical features on non-contrast CT. So the findings include hydronephrosis, which is usually bilateral, although it can be unilateral, smooth tapering of the ureter at the level of the fibrosis, and you very rarely see a ureteric filling defect on an IVP related to invasion of the ureter. A retroperitoneal soft tissue mass is typically seen, which is isodense with muscle on unenhanced films and shows variable contrast enhancement. This typically envelops the great vessels and ureter and is indistinguishable without contrast. CT is also good because it aids in evaluation of lymphadenopathy and underlying malignancy. Interestingly, with CT in idiopathic RPF, we see the typical medial deviation of the proximal to mid-ureter, usually around the L3 to L4 level. However, this is a non-specific finding and is seen in up to 18% of normal patients. With malignant retroperitoneal fibrosis, you'll often see anterior displacement of the aorta and lateral deviation of the ureters. This is a typical CT in a patient with retroperitoneal fibrosis. On the right, you see right hydronephrosis. And lower down in the pelvis at the L3, L4 level, you see this sort of isodense plaque surrounding the IVC and aorta. Another CT showing contrast enhancement of this plaque as it surrounds the aorta. And a CT in a different patient showing involvement of the renal hilum in the upper left here, and all the way down into the pelvis and iliac bifurcation. MRI is often considered to show superior soft tissue delineation, especially with fat-saturated T2 sequences. This allows for distinguishment of RPF from its encased structures, including the ureters, and avoids radiation. Also, contrast with MRI, gadolinium is not contraindicated in renal impairment. There's some new evidence that gadolinium may be implicated in renal dysfunction in patients with pre-existing renal dysfunction, although I don't think that's well established yet.
You could get a radiologist to do an MRI with gadolinium if the crack is really impaired, then they would do it.
There is a contraindication,
Yeah.
but it's rarely very less than 30. Because of the risk of anastasy.
So the conclusion there was that MRI with gadolinium is contraindicated with a GFR less than 30. The characteristic findings on MRI are hypointense mass on T1, similar in intensity to muscle. On T2, you see an elevation in intensity in the acute phase of the disease and a decrease in the mature phase. And an inhomogeneous mass on T2 weighted sequences is typical of malignant RPF. Gadolinium, as I mentioned, can show variable enhancement, typically in the acute phase. These are some MRI images Dr. Chang provided me with showing bilateral hydronephrosis on T2 sequences in the upper left here, and hydroureter down to the proximal mid-ureter. Here you can see the mass surrounding the aorta and IVC. And you can tell that it's much easier to distinguish it from the aorta, IVC, and ureters on MRI. IVP, seldom performed now and also contraindicated in renal impairment, has a typical classic triad of proximal hydronephrosis, which is usually bilateral, medial deviation of the proximal mid-ureter in idiopathic RPF, and extrinsic compression of the mid-ureter. It's a typical IVP showing those findings. Retrograde or antegrade pyelography is not contraindicated in renal impairment and shows similar findings to IVP. It's useful in surgical planning, typically performed when a stent is placed or a nephrostomy tube placed in a uremic or septic patient with RPF. It's useful at delineating the level and extent of ureteral involvement. It's a typical retrograde pyelogram showing the cystoscope in the bladder and thinning of the mid to proximal ureter with proximal hydronephrosis. Renography, also used in retroperitoneal fibrosis, gives an idea of differential renal function and is useful in surgical planning. Occasionally, these patients will present with chronic renal failure and end-stage renal disease, which does not resolve with treatment. PET scanning has been used in retroperitoneal fibrosis, although not commonly used, especially in Canada. This involves administration of fluorodeoxyglucose, or FDG. The use of PET scanning is well established in oncology, and although it has a low specificity for RPF, it's useful in assessing the metabolic activity of the disease and response to treatment. Also, it's useful in detecting occult neoplastic and infectious causes, and at detecting other disease sites, such as are seen in multifocal fibrosclerosis. So differential diagnosis for retroperitoneal fibrosis is retroperitoneal fibromatosis, inflammatory myofibroblastic tumor, inflammatory malignant fibrous histiocytoma, and inflammatory fibrosarcoma. These are in addition to the causes of RPF. So retroperitoneal fibromatosis involves a uniform fibroblast proliferation originating from the muscle and fascia in the retroperitoneum. It's an infiltrative process which tends to recur but does not metastasize and is associated with Gardner syndrome or familial adenomatous polyposis. Inflammatory myofibroblastic tumors seen mainly in children. Typically presents with a huge mass with, again, infiltrating borders, not typical of RPF. Shows myofibroblast proliferation on pathology, and also tends to recur but rarely metastasizes. Inflammatory malignant fibrous histiocytoma and fibrosarcoma show increased cellularity and vascularity, and pathology typically shows nuclear atypism, mitoses, and atypical cells, although these may be rare, making it difficult to distinguish from RPF. So the initial management of RPF involves a prompt diagnosis. Again, these patients typically present 4 to 6 months after onset of symptoms, relief of symptoms, and preservation of renal function. As I mentioned previously, over 50% of patients will present with ureteric obstruction, although over 90% have ureteric involvement and uremia. Some patients will progress to end-stage renal disease, and if they do, they may end up with a kidney transplant from one of these guys. So initial management of the uremic patient involves decompression of hydronephrosis through either percutaneous nephrostomy tube placement or ureteric stenting. Interestingly, placement of ureteric stents is typically not difficult in retroperitoneal fibrosis because of the lack of invasion of the ureter. And it's important to watch for a post-obstructive diuresis in these patients. Further management involves discontinuing precipitant medications. Interestingly, there have been some case reports of spontaneous resolution of retroperitoneal fibrosis after discontinuing medications which are thought to be implicated, followed by a search for occult malignancy, which can involve appropriate imaging as well as percutaneous biopsy.
Are you advocating biopsy of the retroperitoneal mass, or if you find something else?
Of the retroperitoneal mass, and I'll get into the indications for percutaneous biopsy.
You want to do a needle biopsy of the retroperitoneal fibrosis?
Yes. Not necessarily. I'll get into that in a sec. It's the next slide, I think. So percutaneous biopsy. So indications for percutaneous biopsy are controversial. One of the indications historically was prior to any medical management, because these patients would not undergo surgical exploration. So they wouldn't have the advantage of having open, deep biopsies to rule out malignancy. However, this is now disputed, and a lot of patients managed with primary medical management do not undergo percutaneous biopsy. Another indication is prior to any primary surgical management, if there are atypical features or location on MRI or CT that suggest malignancy, lymphadenopathy on MRI or CT, and any history of prior malignancy. Technique for percutaneous biopsy, because of the location of RPF, typically involves CT guidance and a true cut needle, which is preferable to fine needle aspiration because it gives superior pathology results. Problems with percutaneous biopsy are the high false negative rate related to sampling error. Some pathology, gross specimens are typically smooth, flat, and show a grayish-white color. And microscopically, what you see is a non-specific inflammatory process. And in the early stages of the disease, you see collagen bundles, an inflammatory infiltrate consisting of lymphocytes, plasma cells, fibroblasts, macrophages, and occasionally eosinophils, as well as capillary proliferation and a perivascular infiltrate, and edema related to inflammation. Later in the disease, you see an acellular avascular tissue with sheets of hypocellular collagen and scattered calcification. The inflammatory process or acute process is typically noted at the margins of the mass. So diagnostic clues in secondary retroperitoneal fibrosis on pathology include tumor islands, which suggest malignancy, a monoclonal infiltrate, which suggests lymphoma, granulomas, which suggest TB, hemosiderin deposits, which suggest a traumatic cause. And when you see sclerosis with a minimal inflammatory response, often think of radiation. It's a typical pathology slide which shows the inflammatory infiltrate in retroperitoneal fibrosis. You see peripherally here there's a diffuse pattern, which is the most common, and in the center there's a nodular pattern, which is also quite common. Here on higher powered views, you see perivascular inflammatory infiltration of the retroperitoneum with monocytes and rare eosinophils. The arrowheads represent vessels in the retroperitoneum, here, here, here. And the arrows represent monocytic infiltrate. This is another pathology slide showing a diffuse monocytic infiltrate amongst thick collagen bundles, which is more typical of the chronic phase of the disease. So treatment goals in retroperitoneal fibrosis are to halt progression, to relieve obstruction of the ureters and other structures, to suppress the acute phase reaction and treat systemic manifestations of the disease, and to prevent recurrence and relapse. Medical management of RPF is now considered first line. Some of the reasons for this are the morbidity of ureterolysis, the fact that efficacy for corticosteroids in particular has been shown, but only in small case series. Appropriate image-guided biopsy techniques are now present, which enable exclusion of malignancy, although it's not always entirely possible. And there is more sensitive imaging available for diagnosis and follow-up of patients treated medically. However, there are no randomized controlled trials to date that compare medical or surgical management. Options for medical management include corticosteroids, immunosuppressants, and other medications. Corticosteroids are thought to act through decreasing cytokine production, decreasing the inflammatory response, decreasing collagen synthesis and maturation. Historical indications for corticosteroids were a poor surgical candidate, neoadjuvant therapy in the context of extensive vascular involvement, making for a difficult open resection, and any failed surgery or recurrence. Contemporary indications are as first line or initial management and as adjuvant therapy in combination with surgery. Overall, there's approximately 80% clinical response rate to corticosteroids. This is based on 140 cases in multiple case series in the literature on idiopathic RPF. These patients typically show a response which includes a decrease in pain and constitutional symptoms, which occurs within days of treatment, a decrease in size of the retroperitoneal mass, a decrease in compression of the ureters or IVC, a decrease in the ESR, and subsequent diuresis with resolution of hydronephrosis. There's a 10% recurrence rate in patients who respond initially. However, there's no consensus on the corticosteroid of choice, the dose, or its duration. A recent publication in the Journal of Urology in 2002 by Cater et al. Was a case series of only 11 patients, although this is pretty significant for retroperitoneal fibrosis given its rarity. Cater used steroid monotherapy consisting of prednisolone, 60 milligrams alternate days for 2 months, tapering to 5 milligrams over the next 2 months, and continuing for a 2-year total treatment, and followed these patients up for 63 months. He showed a clinical response rate of 82%, so 9 patients out of his initial 11. The clinical response that he documented, including regression of the fibrotic plaque, a resolution of hydronephrosis, and this response was typically seen within 6 months, but up to 20 months after treatment. Clinical failures seen in 2 patients included need for reinitiation of steroid therapy and need for ureterolysis in 1 patient. So, with corticosteroids, there are several predictors of whether the patient will respond or not. Again, this is in patients with idiopathic RPF, not secondary RPF. These include systemic manifestations, leukocytosis, an elevated ESR, positive anti-nuclear antibody, or documented active inflammation on biopsy. Disadvantages of corticosteroid therapy include its adverse effects, which are well known, including weight gain, diabetes, osteoporosis, avascular necrosis, moon phases, and others. And corticosteroids, importantly, are contraindicated in retroperitoneal fibrosis secondary to infectious processes. To minimize the adverse effects, some have advocated for administration of H2 blockers and calcium supplementation in patients treated with steroid therapy. Also, a lower dose is possible when patients are also treated with other immunosuppressants, which I'll get into. So in terms of immunosuppressive therapy for RPF, there are only case reports in the literature, and it's a very small case series. Some of the agents studied include azathioprine, given at a dose at 2.5 milligrams per kilogram daily for 3 to 6 months, then tapering for another 6 months for a total 12-month treatment. Cyclophosphamide at 2 milligrams per kilogram daily, tapered over a 6-month total course. Cyclosporin, penicillamine, and mycophenolate mofetil. Immunosuppressive therapy is typically used in combination with steroids, but should be avoided in elderly and uremic patients because of its multiple toxicities. Other medications used in the management of RPF include tamoxifen, 20 milligrams daily for 12 months. Tamoxifen is a non-steroidal anti-estrogen, which is thought to exert its effect through mediation of TGF-beta, and has been shown to be effective in treatment of desmoid tumors, which have a similar basis to RPF. It's often used as monotherapy, but can be used in combination with corticosteroids or in patients with contraindications to steroids. And it's a good alternative when steroid treatment fails in a patient who's not a good surgical candidate. Other medications include medroxyprogesterone acetate and progesterone. again, their mechanism of action is really very poorly understood. So indications for surgical management currently include only failure of medical management. So all patients should undergo medical management initially unless they have a contraindication. Benefit of surgery as primary management includes the opportunity to provide deep open biopsies, which effectively exclude malignancy. But its disadvantages include that it does not prevent progression or recurrence, and recurrence is seen in up to 50% of patients that don't receive adjuvant therapy. Also, with surgery, there's a minimal impact on the systemic manifestations and constitutional symptoms related to the underlying autoimmune and inflammatory process. So, surgical options. It's Derek and I here. And I don't know. It's a patient who had RPF and then had renal failure. Just joking. So surgical options include ureterolysis, which can be performed open or laparoscopic. And should this fail, alleal or appendiceal interposition of the ureter, Boari flap, auto-transplantation. And in patients who are not suitable candidates for open surgery, chronic stenting or nephrostomy drainage. And nephrectomy is seldom necessary, but may be necessary in patients who present with non-functioning kidneys. So open ureterolysis is gold standard in terms of surgical management for RPF. The approach typically involves preoperative stenting to facilitate identification and dissection of the ureters. And the stents are usually removed 6 to 8 weeks postoperatively. And some reports in the literature do not advocate for preoperative stenting, although I think it would make for a much easier dissection. The approach is through a midline transperitoneal incision with medial mobilization of the colon on both sides, followed by deep open biopsies and frozen section to exclude malignancy. Some slides from Hinman's showing the technique for open ureterolysis. So a bilateral dissection of the ureter should be performed even in patients with unilateral hydronephrosis, because the process is typically bilateral, even if only one ureter appears to be involved with hydronephrosis. Dissection should begin at the distal ureter, which is non-dilated and less susceptible to injury. The thinner dilated proximal segment is often injured when dissection begins higher up. Right angle clamp or dissector is typically inserted between the ureter and fibrotic mass, followed by excision of the ureter from the fibrous tissue. It's important to avoid ureteral injury, which can result in urine leak and increased rate of recurrence, as well as late ischemic stricturing. Ureterotomy is seldom necessary in these patients. So in order to prevent recurrence of RPF, there's several techniques which have been described, the first of which involved lateral displacement of the ureter into an uninvolved area of retroperitoneal fat with securing of the peritoneum medial to the psoas to sort of trap the ureter out laterally where the process is unlikely to recur. The second technique involves intraperitoneal displacement. This was described by Tressiter in 1972, which involves mobilization and dissection of the ureter, followed by closure of the peritoneum posterior to the ureter to effectively intraperitonealize the ureter. And with this technique, it's important to avoid obstruction of the ureter at the hiatus of the closure of the peritoneum at the proximal and distal ends, so here and at the bottom. A third and probably the most commonly used technique involves intraperitoneal displacement as previously described, followed by omental wrapping of the ureter. This was described by Karani in 1982 and is thought to be the definitive approach for patients with extensive RPF. So you can see here the omental wrapping of the ureter. So in order to perform the omental wrap, the omentum is mobilized from the transverse colonic attachments, divided along its midline up to the gastric attachment. resulting in two pedicles, which are based on the short gastric vessels at the gastric wall. Division of the short gastric vessels and the blood supply coming from the gastroepiploic arteries on both sides. The omentum is then tacked in place with absorbable sutures. Some reports in the literature describe the use of PTFE vascular grafts in patients without omentum available. The benefits of omental wrapping include protection from extrinsic compression and blood supply to prevent ischemia. Interestingly, there's also a higher rate of postoperative ileus in patients in which an omental wrap is performed, and also late obstruction of the bowel. So open ureterolysis. This is a retrospective review by Barbelius and Liatzikos from Greece in the International Journal of Urology and Nephrology, 1999. With 21 patients with idiopathic RPF, mean age of 55, treated with either intraperitoneal displacement in 9 patients or lateral displacement in 12. And they showed basically no difference in radiologic or clinical outcome at 1 year. Laparoscopic ureterolysis was first reported by Cavusi and Clayman in 1992 in the Journal of Urology. And a subsequent case series by Fujita et al. In the Journal of Endourology, 2002, involved 13 patients, 7 with bilateral disease and 6 with unilateral disease, all of which had idiopathic RPF. They were treated with preoperative stenting. 4-port transperitoneal approach was used. There was intraperitoneal displacement of the ureters, but no omental wrapping. The conversion rate was 50%. This was related to an iliac vein injury and a second patient with a dense fibrosis. Mean OR time was 381 minutes for bilateral dissection and 192 minutes for unilateral dissection. Mean hospital stay 4 days. A complication rate of 30%, including prolonged ileus, urinary retention, port site erythema, and epididymitis. Follow-up was performed at up to 30 months and showed a lack of upper tract obstruction in 92% of patients. However, laparoscopic ureterolysis is technically difficult and does have a prolonged operative time. And despite this, the AUA update series in 2005, lesson 3, suggests that this approach has been proven to be less morbid and should be the procedure of choice in centers with the ability. And this was based on a study by Elashry et al. In 1996, which showed these patients had decreased analgesic requirements, decreased hospital stay, and decreased recovery time. This is a paper here. It was a case control study. But interestingly, you can see the two groups were quite dissimilar. The laparoscopic group was all female patients, which is unusual in retroperitoneal fibrosis, whereas in the open group, only 2 patients were female, which is more typical. The mean age in the laparoscopic group was 20 years less than the mean age in the open group, so 36 versus 55. Mean blood loss was slightly less in the laparoscopic group. The mean hospital stay was significantly less, 2.8 days versus 10 days. Mean time to oral intake, 1 day versus 5 days. And mean time to return to work and usual activities, only 2 days with laparoscopic ureterolysis versus 7 days with open. That's days after discharge. Yeah. So stricture rates or stricture lengths, were 4 centimeters in the female patients, only 3 in the open patients. So abdominal aortic aneurysm, often seen in patients with retroperitoneal fibrosis, and often associated with causing retroperitoneal fibrosis. There are 3 different types of retroperitoneal fibrosis described here. Idiopathic retroperitoneal fibrosis related to a non-dilated aorta, which I described previously with leakage of seroid and oxidized LDL into the adventitia, resulting in periaortic fibrosis and obstruction of the ureter on the left there. In the middle, you see inflammatory abdominal aortic aneurysm with a dilated aorta, but in this case, no involvement of the ureter. And finally, on the far side, you see perianeurysmal retroperitoneal fibrosis related to a dilated aorta with involvement of the ureter. So the left and right are examples of where you see ureteric involvement with abdominal aneurysm. So in patients undergoing aneurysmectomy or atectomy for a AAA, ureterolysis remains controversial. Without a concomitant ureterolysis, some patients will resolve their hydronephrosis, some will show persistence, and some will even progress. So the controversy basically involves whether or not to perform ureterolysis at the time of abdominal aneurysm repair. There's probably the most quoted study on this by Spezial et al. In the Journal of Urology in 2001. It was only a case series of 14 patients, all of whom had inflammatory abdominal aortic aneurysms and subsequent retroperitoneal fibrosis with severe renal impairment. These patients underwent an open aneurysm atectomy alone, and at follow-up at 48 months showed a response rate of 75%, which included disappearance of the RPF on CT and resolution of hydronephrosis. The mortality rate was 7%. One patient passed away, and there was a stent requirement postoperatively in one patient. Finally, endovascular stent graft repair, described in a case report by Raring et al. In 2001, with spontaneous resolution of hydronephrosis in a patient with ureteric obstruction subsequent to RPF. Complications of surgery include ureteral stricture related to ureterotomy at the time of surgery, urine leak, ureteral devascularization, recurrence of retroperitoneal fibrosis, late intestinal obstruction, which, as I mentioned, is more common in patients who undergo an omental wrapping of the ureter, and post-obstructive diuresis. Follow-up, although there aren't any clear guidelines on this, should be long-term, given that the disease can recur up to 16 years after its initial presentation. Patients should be monitored in terms of their symptoms, their renal function, their acute phase reactants such as ESR and CRP, which are indications of the activity level of the disease and can suggest recurrence. Routine ultrasound, which can assess recurrence of ureteral obstruction, and CT or MRI to assess the size of the mass in response to therapy. This diagram shows a management algorithm. The top here you see a diagnosis. You see a diagnosis of retroperitoneal fibrosis, an idiopathic retroperitoneal fibrosis, which is on the far left there, with ureteral involvement. So again, going left. These patients should be treated with ureteral stents or nephrostomy tubes and steroids. And if they fail, they go on to surgical therapy. All other patients are treated with medical therapy. And this was from the Lancet Review article from 2007. So in summary, retroperitoneal fibrosis is an obscure and multifaceted disease, which is difficult to diagnose and difficult to establish a cause for. And medical management is now first-line therapy, although there are no randomized controlled trials to suggest that it's superior to surgical management. That's it. Thank you.